So the hot topic of the day is adult immunizations. And you guys know me, as I started to dig into this, I was like, oh, we've got a lot of different stuff to talk about. So I actually am, instead of diving straight into the exact immunizations that, we could potentially need or discuss, I'm going to talk a little bit about immunizations, period. And so to start with, really, there are kind of four types of vaccines. And if you heard me this morning on the radio, we kind of talked about some of these things. But we'll start. So live attenuated vaccines, those are basically vaccines that are the true pathogen that we're trying to prevent and protect ourselves against, but they're weakened. So they tend to stimulate a good immune response, but they can cause disease. We need to avoid them in immunocompromised people, in pregnant women. That would be a bad idea. Another potential maybe downside to that is they can be contaminated with other viruses. And that doesn't happen often, but it could happen. Uh, and then we have to be careful in terms really of stability when it comes to live attenuated vaccines. They need to be refrigerated, and we a lot of times have to use a diluent with it. And once those two things are mixed up in this powder form in the diluent, um, it, it's got to be used like in 6 hours or it has to be thrown out. And so some of the vaccines that would be typical for this would be TB, which we don't do in this country. Oral polio, not done in this country at this point. Measles would be one of those. Rotavirus. Rotavirus is for children, so not necessarily a topic for us today, but yellow fever would be one. The other thing that falls in that is some of our flu vaccines. So that could be a live attenuated vaccine. The next group of vaccines would be inactivated or killed antigens. So think about the inactivated vaccine as the pathogen, what we're protecting against or want the immune response to is dead. So we find that we have a more variable immune response. It might not be as long lived, so it might require multiple doses. These can't cause a disease, so you're not going to get disease from them. And they tend to be more stable in transport. A couple of those would be pertussis, and our polio vaccine would be inactivated polio vaccine would be another one of those. Again, another childhood vaccine. The subunit vaccines are interesting in that there are three different types of subunit vaccines. And when we talk about a subunit, we talk about this antigen or this piece that we're trying to get an immune response to. And you're hearing about it a bit now with COVID, like everybody's heard about that S spike, and so that's where vaccines are being focused on, that S spike. So the subunit contains an antigenic part of the pathogen, no live virus or bacteria, and these can be either protein based, they can be polysaccharide or sugar based, or they could be a conjugate. And so our protein based tend to be like pertussis, hepatitis B. That polysaccharide is meningitis or pneumococcal. The conjugate would be Haemophilus influenza type B and pneumococcal. So you can see there's overlap in some of these vaccines, and I'm not going to get to COVID tonight because I think there's not enough information for me to talk too much about it yet. But you're going to see that we're going to be looking at a couple of different types. So the last type of vaccine is a toxoid vaccine, and a toxoid basically comes from toxins. And when we think about that, like the classic cases will be tetanus and diphtheria. And so those, if we get infected with tetanus or with diphtheria, basically it's not necessarily the bacteria that's the problem, but it's the toxin they create, and that creates our immune response to that. So it's our reaction to this toxin. So basically what we're doing is taking an inactivated toxin and then using that to trigger the immune response. These tend to be longer lasting. They don't cause disease either. And this one, I'm going to say it now so I don't forget later. Really interesting study. I think I'll remember it, out of Oregon Health Sciences University in 2015 or 2016. I think it got published in 2018, that they found that tetanus and diphtheria, the half-life of that vaccine, so that length of time that that vaccine is good, it's longer than 10 years. So they've really questioned whether we need to be getting that every 10 years or not. So that's interesting. So moving on, antigens, we kind of talked about that. So the antigen is what we are presenting to our immune system to create this immune response. So it can be a pathogen, a part of a pathogen, and a pathogen being that bacteria or virus. So other components in all of these vaccines are stabilizers. So stabilizers can be magnesium chloride, magnesium sulfate, lactose and sorbitol and gelatin. But basically, these things are added to vaccines to really help keep them stable, hence stabilizers, maintain effectiveness in storage. So really can make a difference with the pH, the temperature, and some of these, especially if we're dealing with some of these protein subunit things, just so they don't aggregate or clump. So there, and I guess the rationale for number one, explaining when you are getting a vaccine, what actually are you getting? And then number two, you can see where we can have reactions to a variety of things. Adjuvants. Adjuvants are added to vaccines, generally not needed in those live attenuated vaccines because those are going to stimulate an immune response. But adjuvants are added to vaccines to further bolster that immune response. The most common are aluminum salts. Also used are polysorbate 80, polysorbate 20, squalene, mineral oil, vitamin E. And you can see and this is just like a depiction, of what happens. So if we have an antigen gets put in, we have dendritic cells reacting and pro-inflammatory things, our little monocytes and our macrophages at the site of the injection, and then you can see the reaction. Well, when there's an adjuvant with it, it really causes a more theoretic, robust response. So that's the idea behind why there are adjuvants in our vaccines. So some concerns with adjuvants, generally it is often the adjuvant that causes that injection site reaction. So that sore arm and the redness. And certainly people will get fever, maybe feel achy, some of those things. And those can be related to adjuvants. Certainly with those live attenuated vaccines, it can be kind of mild illness, if you will, and it's your immune system responding, which we're trying, that's what we're doing this for. Other concerns is that we could really overactivate an immune system. And there are some immune-related diseases that we've seen, and often we think that those are related to the adjuvants. And when it comes down to that, I have actually seen in my clinical practice one case of Guillain-Barré following a flu vaccine, and that's not something that anybody wants. There was back in, I think it was 2009 in the UK, there was a flu vaccine and it was called Pandemrix of all things. But that they were finding people were having an adverse reaction of having narcolepsy. So they just drop and, fall asleep. So we know this has happened. There's also Gulf War syndrome, I think a lot of people have heard about, and in many of these folks with Gulf War syndrome, they've found antibodies to the squalene that was used in some of those vaccines. So the other thing you can get is a little bit of myofasciitis. So myo, thinking about muscle, and fascia. And that, like, I think some of the, like, that would be like if you got a vaccine and you've like have this ongoing lump, you know, most of the time those go away, but sometimes they won't. And we can see an aluminum salt deposit. And then lastly, there is a whole category of syndrome called ASIA. It's autoimmune inflammatory syndrome induced by adjuvants. So it's a spectrum of clinical conditions. And so we do see these things in people. So it's not, somebody has an adverse reaction, you know, the challenge is it needs to be reported. And really reporting it comes down to a provider reporting it. And so I would say, you know, my stance on this is if you have a vaccine and you have an adverse reaction, I need to hear about it. And maybe so does the pharmacist that gave it to you, because it has to be posted into a vaccine injury site. And so I think a lot of times we don't get, I think a lot of them don't get reported, basically, and that's not helping science advance at all. The other thing that is found in vaccines are some antibiotics. They're really trace amounts of antibiotic, but it helps prevent bacterial contamination in those cell cultures where basically viruses are grown, you know, and that can be human or animal cells. So for some people, like, that's definitely a concern. There hasn't been in many years, we're better at, I guess, screening those cells, especially if they're human or animal cells, for other viruses, because the last thing you'd want to do is culture a specific vaccine, you know, grow it in a cell and then inject it into somebody and find out there was another virus within that cell culture. That, as you can imagine, would be unfortunate. It has happened historically. I'm not aware that it's happened recently at all. And the main antibiotic that gets used is, it's mainly it's neomycin as an antibiotic, and that would be in the MMR, which generally doesn't really have much to do with all of us as adults, and polio, same thing again. And then lastly, kind of preservatives. And preservatives get added to some single dose vial, but more to multi-dose vials. So when you go somewhere, people, you know, if a lot of times like a flu vaccine might be, there's 10 vaccines in a bottle, or, you know, things like that. But so preservatives primarily get put in those multi-dose vials. And I think everybody's heard about thimerosal. That is definitely a concern. It's been used since the 30s. Ethyl mercury is the problem there, and it's been very controversial over time. And it helps reduce storage requirements and costs. So there's reasons why we use some things. Formaldehyde is another thing, other phenol derivatives. And like the formaldehyde inactivates viruses, it detoxifies bacterial toxins. And when the vaccine goes through this purification process, it really removes most of this stuff from the vaccines. So moving on to routes of administration, figured we might as well review this. Most of us as adults, if we get a vaccine, it's an intramuscular vaccine. We end up getting it up into our deltoid. We can get subcutaneous vaccines. That goes beneath the skin, but above the muscle. Intradermal is within the skin. And BCG, which is a tetanus vaccine, we don't use that in our country, but that is the only one that does that. And I think many of you, we can liken it to when you got that PPD or a TB time test. So it goes just right in the dermis and you get that little bubble. But we don't really use that for any other vaccine currently. Intranasal, that's basically the flu vaccine is really our only intranasal one right now. In 2000, interestingly, their flu vaccine that they had that year that was inactivated uh, virus, it actually ended up being pulled because it was associated with Bell's palsy. And so if you got the vaccine in your right nostril or your left nostril, they were seeing association of Bell's palsy on that side. And so that's a bit interesting historical information. And then oral, the only oral vaccines that we have are oral polio, and that is not used. It's not used in our country anymore. Many of us got oral polio, but really now it's used in third world countries um, because of cost, essentially, right now. And then the other one that we have is rotavirus, which is a childhood vaccine. So we're going to talk about CDC recommendations, and I'm going to kind of go back and forth here, talking about each of these different things, and then we'll kind of hit some highlights. I was struggling a bit with how to figure out how to present this. So clearly, you can see this is this one I took off of the Annals of Internal Medicine and the Council for Immune Prophylaxis. So this is basically the CDC recommendations. This is available on the CDC website. You can see there's different flu vaccines, and we can come back to this, but I'm going to run through really each one of these things so we can talk about like who's it for and those different things. So flu vaccine changes yearly, and really it's based on a best educated guess. There are three different vaccines. There's an inactivated, a recombinant, and a live attenuated, which is that intranasal dose. And interestingly, that one shouldn't be used over age 50. I'm going to figure out how I want to share something with you. So I am part of an organization called Physicians for Informed Consent. This is available to any of you. You can go to the physiciansforinformedconsent.org site and see this. So interesting things about flu vaccine, and this is referenced, and you'll see that at the bottom. But there is, there's this question about a 65% increase of non-flu respiratory illness in populations that get the flu vaccine, and so. And it's really within 14 days of the flu vaccine. So it's interesting, and you could get another thing that would be fever, headache, aches, pains, cough, all of those same things. So there is a risk. Interestingly, despite the mandates and sometimes, people are told, well, you have to get a flu vaccine to work here. In studies, it's not really shown to reduce the demand on hospitals, which is interesting and not the message that we get. Thirdly, it doesn't really prevent spread of flu as well as we are being told. And I'll let people read through this, but I just wanted people to see it. It's well vetted information, and I think it's good to know. I think everybody knows about the flu vaccine effectiveness. That can be anywhere from 30 to 50% effective in a given year. And that's because we have to really kind of guess what it's going to be this year. And there's no shortcut around that. There is question that repeated doses of flu vaccine can actually increase the risk of it not working well. Death from the flu is rare in kids. It doesn't reduce the death from pneumonia and the flu. Not in studies, it doesn't bear out. Interestingly, patients, there's a thing around the hospital and a lot of bigger systems that say, as a provider or a healthcare worker, you need to get a flu vaccine in order so that you don't spread it. Well, there's not actually really much evidence to support that. And basically that the mandates aren't not very science-based. So this, I'll link to this when I send out a little follow-up for you guys, but I think this is good information. There's other information on this website that anybody can access as well. So we'll go back to, let's go back to our slides. Yay, there we go. All right, tetanus, diphtheria, and pertussis. So this is generally given as a series to kids. You know, this is the one that we think about. You think about Clostridium, diphtheria, tetanus, like we're talking about, you know, this is the whole, like we tend to step on a rusty nail or something, but this has always been every 10 years, whether we do a tetanus, diphtheria, or a tetanus, diphtheria, and pertussis. And probably in the last, probably 6-7 years, there's been a push to have, as adults, to get one more tetanus with the pertussis, thinking that maybe that pertussis vaccine that we got as kids had worn off. And so pertussis is whooping cough, and we probably don't want that. Interestingly, I did put in here about this study. If we spaced out this tetanus and diphtheria vaccine, which I'm sure no vaccine manufacturer would want, it could save us over $1 billion over 4 years. And interestingly, it is not given in the UK after childhood. So that's really interesting. And so I linked to this study in here, which I think is interesting, and it didn't really get much press. Measles, mumps, and rubella. This is generally given in childhood, occasionally with outbreaks. You know, a couple of years ago, there was a lot of questions around, should I get another one of these? That is not a current recommendation at all. This is a live attenuated vaccine. So if you are immunocompromised, I don't think any of us on this call are pregnant, you know, this is not the right vaccine. The other thing you'd think about too is if you live with somebody who might be immunocompromised, you know, you want to be really careful. And I would say the same thing for folks that are grandparents. You know, you want to know when grandchildren get MMR or varicella vaccines, those kind of things. This is generally 1 or 2 dose series. And if born after 57, so if you were born before 57, we just assume everybody had gotten sick with these things, so we don't need to worry about it. But if you don't have a record of prior immunization, or there's some specific circumstances in which those can be given. Varicella is chickenpox. That is a live attenuated vaccine. This is recommended if you've not had chickenpox or if you were born after 1980. And we just don't see, for many of us that are older, you know, most of us had chickenpox as kid, but kids nowadays, you know, like there aren't chickenpox parties anymore or any of those things, not really. So this vaccine came out when I was in residency, so 20 plus years ago. And I remember discussing how it was a vaccine of social convenience. Because at that point, that's when we started to move where we have both parents are working. And if, you know, if your child came down with chickenpox, like somebody's going to be home for 2 weeks with this kid. So it turns out, you know, if a child doesn't get vaccinated and they get through their teenage years and they've not had chickenpox, I would suggest maybe getting a vaccine, mostly because it's an inconvenience as a child. Some kids can get pretty sick with it, but most people get all those little blistery pox and a fever and a runny nose, and then kids get better. But as adults, we can get pretty darn sick with chickenpox, so that's a problem. So again, not used in pregnancy or in those that are immunocompromised because of this live attenuated vaccine. So zoster and shingles, this has been a hot question for me recently. This again is live attenuated or recombinant. And so 1 in 3 people will get shingles, often triggered by stress, disease, medications. 15% of the 33% can get this post-herpetic neuralgia, and that's kind of the dreaded thing. So we initially had the Zostavax, which was the live attenuated, and it really was not a very good vaccine, flat out. The Shingrix, which is our current vaccine, is a recombinant, and this is a more effective vaccine, about 97% for those 50 to 70, maybe approximately 90% greater than 70. You need 2 doses of this vaccine. And so I think the thing, there's a link to another article here. You know, I think the thing that we have to think about, you know, and this is a choice for everybody, you know, all right, if, you know, theoretically there's a 33% chance that I'm going to get shingles. And if I get it, there's a 15% chance that I get the post-herpetic neuralgia. So that tells you 66 point whatever percent of people don't get shingles. And, you know, so there's even a smaller percentage. I have had people be absolutely miserable with post-herpetic neuralgia. And I've had some people be like just have shingles and not get it. So this is one that I would say we all have to make a choice. Like, is shingles going to kill you? Probably not. Could it be really painful? Absolutely could be. So it's just a conversation to have. So I don't think it's a hard and fast yes, no on this vaccine. And I'm sorry if that's not direct enough. That's not my intent, but that's the reality of it. HPV. For HPV is human papillomavirus. This is linked to cervical cancer. We screen for cervical cancer. We have very effective screening with pap smears, HPV testing. And so the likelihood, if you are getting screenings, obviously this is pertaining to women, the likelihood of you dying from cervical cancer is very low. It's often given in adolescents, girls and boys. It can be given to those ages 27 to 45, and that requires a conversation. Kind of the main issue with this has been side effects. There's questions about fertility problems for young gals. There have been people who have just gotten syncope or passing out. There's been some different odd side effects with this vaccine. Japan and Colombia no longer recommend them. They did initially, but they do not. You know, and the other thing to think about when we talk about all these things, you know, if you get tetanus, you can die from tetanus. Like, we know that. And so getting that is, I would argue, is like, to me, that is kind of a no-brainer to get that. When it comes to something like HPV, we have treatment available and we have screening available. So I would say this is one of those vaccines that I think necessitates just having a conversation and weighing risk benefit between you and your provider, or, you know, and your family, who it would relate to. So that's a bit on HPV. Pneumonia vaccine. So there's 2 of those. There's this pneumococcal conjugate, PCV13, and this we've used for quite some time. It's designed to protect against pneumonia. The newer one is the pneumococcal polysaccharide, so it's PPSV23. So it's really aimed against 23 different subtypes. And this is generally a 1 dose, 65 or older. And since we have now this PPSV23, like, that is really the way to go. And I don't know that there would be a reason, unless there would be some specific allergen to something in the PPSV to get the PCV13. Hepatitis A and B, these by virtue of hepatitis, that's what they're designed to protect against. Hepatitis B, we know, is bloodborne pathogen. It can be sexually transmitted. More common with IV drug abuse, men having sex with men, healthcare workers could be at risk, paramedics. So the concern about hepatitis B, it's a long-term illness and can increase your risk of cancer. We don't have a vaccine to hepatitis C. Hep A, most of the time this is spread fecal oral. It's generally a self-limited disease. People will get basically gastroenteritis, so nausea, vomiting, diarrhea, those kind of things. I would say Hep A is one of those things. It is given in children here. I should have looked, but I wasn't really looking at childhood vaccines. Like where I trained in Minnesota, Hep A was not a standard vaccine. Here, because of the villages and water source issues and those kind of things, Hep A is more of a recommended vaccine. Hep A, if you've ever been to Mexico, we'll hear once in a while of outbreaks, and it's like people will go and you'll say like, don't eat ice cubes, drink bottled water, that kind of stuff, because you're really worried about that spread. Because all it takes maybe in a restaurant is a cook, a food handler, somebody that goes to the bathroom, doesn't wash their hands well, and now there's Hep A on your food. These are 2 or 3 dose series at this point. If you haven't had those, if you were going to more of a third world country, this is, I'd probably make sure you have Hep A, and, just knowing you could get sick. Hep B, not as likely because it's bloodborne pathogen. So, I think these are given pretty standard to healthcare workers. Mostly Hep A, though, travel related, but there are no countries that I'm aware that you can't get into because you don't have a Hep A vaccine. So there's choices. Meningitis vaccine, this is generally given in that 19 to 23 age group. Initially, this was given in the military, and then they started giving this to kids before they go to college, or young adults before they go to college, because of dorms and spreading. It's also needed if you don't have a spleen, and maybe consider it if you're going to a country that is experiencing an outbreak, and I'm not aware of one right now. So we largely have eradicated meningitis. We just don't see it now. And I think a lot of that has to do with the fact that we vaccinate children against strep pneumonia. We vaccinate them against Haemophilus influenza. And those were kind of a couple of the big reasons that kids developed meningitis when they were little. And I have seen only, one case of Neisseria meningitis in a young adult when I was still in training. So largely not much of an issue, but if you have a child going to school, it may be required. Haemophilus influenza type B, this is generally given in childhood to protect against infection. It used to cause ear infections, meningitis, pneumonia. Occasionally I haven't in many years seen an adult with a Haemophilus influenza pneumonia, but generally this is given to somebody who doesn't have a spleen and somebody who is kind of in a post stem cell transplant state. So, and with that, references, so the references that were in here within the talk, and then kind of references to, there's a really great this World Health Organization PDF is really cool because it breaks down those different vaccine types, and it's really helpful. And then some information about vaccine adjuvants, link to that Physicians for Informed Consent, which I think has got some good information. And then 2 of kind of my favorite books when I'm talking about vaccines are the Vaccine Book by Robert Sears, and then the Vaccine Friendly Plan by Paul Thomas and Jennifer Margulis. So those are references, and this was up on the top of Blueberry Knoll on Saturday. It was actually really quite nice up there. So let me see what we got for, looks like we got some questions. Adverse effects, short-lived or long-term? Super, super awesome question. So adverse effects, like if you were to develop a fever, get a lump in your arm, or redness, some of those things can be short-lived, but there's concern about, really concerned about long-term effects. So certainly if you end up with like this overwhelming immune response to a particular vaccine, you could develop an autoimmune disease. So that certainly could happen. I will share the link to the flu vaccine, and then, yeah, the meningitis vaccine, it's not entirely a strong recommendation, but some schools will say if you have to have that vaccine to come to school. So that's kind of that. Any other questions or?